Good afternoon, respected colleagues and chairpersons. My topic for today is atezolizumab in first-line metastatic non-small cell lung cancer. So we can see here the three global phase 3 studies in the first-line setting with Empower 110, which obviously is atezo monotherapy, whether it's a better agent than chemo in PD-L1 selected chemotherapy naive patients. Empower 130, where we have to know if the steroid sparing chemotherapy a better combination partner for the atezolizumab, and Empower 150, obviously, which is the most important point of discussion, whether addition of atezolizumab to the standard of care bevacizumab plus Pacli and Carbo has any clinical benefit. So we'll be going straight to the Empower 150 for the atezolizumab plus chemo and bevacizumab in first line setting. So this is the stage 4 recurrent metastatic non-squamous lung cancer, chemo naive, PD-L1 IHC expression of stratification factor, sex and liver metastasis. The arm A was atezo with carbo and Pacli, arm B with the 4-drug combination versus the standard of care chemo with bevacizumab in arm C, which is the control. And on maintenance therapy, we can see here in arm B, we continued with atezo and the bev, and the co-primary endpoints was PFS and the OS. So what we see here that the baseline characteristics in these arms were very well balanced. There were 14% of patients had liver mets at baseline, which was the stratification factor. 10% had EGFR mutations, and these were balanced. There was approximately 50-50% split between the positive and the negative PD-L1 status in patients. So we can see here a significant OS benefit with addition of the atezolizumab in the intention treat arm. So here in the arm B, we can see the median overall survival of about benefit of 19.5 months, which obviously is shown with the median OS of about 4.5 months. It was definitely clinically meaningful. The overall response and the duration of response were also improved. There was a higher proportion of patients who responded to this treatment with the combination. And definitely we can see here that the median duration of response in arm B was significant at 11.5 months compared to arm C. It was also observed that there was OS benefit across all PD-L1 subgroups. The OS benefit was observed across all PD-L1 subgroups. So in PD-L1 positive patients as well as in negative patients, there is in the median OS benefit was 22.5 months, and here it was 16.9 months. Both were beneficial. So coming to the subgroup analysis, we had some key subgroups in the study where obviously this combination has been proved to be much more beneficial. First, we have the EGFR positive patients. So we can see here that the overall survival benefit for patients with EGFR ALK positive mutations were observed only with the Empower 150 regimen. So this is a case which a 60-year-old man, never smoker, present with lymphadenopathy, cough, weight loss with bilateral cervical lymphadenopathy. This patient this was the scan findings. So it was EGFR positive exon 19 deletion with co-mutation of P53. Patient was given osimertinib, progressed on that, and after a few months disease progression, the lesions increased, and then patient had brain MRI metastasis, which is symptomatically stable. So in this situation, the patient was continued with the third option with atezo, bev, and chemotherapy. And we could see here that the monotherapy had limited efficacy in previously treated EGFR positive NSCLC. But however, with this study, we can see here that the EGFR signal activation increased the VEGF production, and patients had better benefit. So the different EGFR subgroups were the EGFR mutational ALK rearrangement, the EGFR mutation sensitizing mutation, as well as the sensitizing mutations on prior TKI therapy, all were taken in the subgroup for this treatment. There was PFS benefit, so the PFS curves separated at around 6 months with median PFS benefit of 9.7 months. The OS benefit in the EGFR mutation group also showed significant benefit. There was continued clear separation of curves with OS benefit being shown. With OS benefit in patients with sensitizing EGFR arms with prior TKI therapy, there was continued clear separation as well, and OS benefit was seen with the 4-drug combination. Now, 6 months, the patients received 4-drug and then 2-drug therapy maintenance. And we can see here the fair response that happened in this case. Now, then comes the next subgroup, liver mets. So in liver mets, this study has shown that there has been a significant OS benefit for patients with liver mets. So you have a similar kind of a case where the patient was given the 4-drug combination. We can see here the changes in the liver, and obviously with this study we can say that with the targetable mutation negative PD-L1 1% or low PD-L1 status and liver mets can influence a decision to obviously follow this study and give the 4-drug combination if patients have good performance status and can continue. Patients with liver mets have a very poor prognosis. So in such cases, this can help the patients have a better overall survival data. So all patients with liver mets have clinically meaningful survival with this regimen, despite that it is a negative prognostic factors in NSCLC with a PFS benefit of 8.2 months. And OS benefit was also observed in liver mets when BEV was added to atezolizumab. The curves obviously separate early and they have remained separated, showing improved overall survival. Addition of the bevacizumab to the atezolizumab and chemotherapy improved both overall response and duration of response in patients with liver mets. And they also again continued for the 4 months, 4 drugs in 6 months with 2-drug therapy, and then have been on 2 years of follow-up. Patients in brain mets also have been shown to produce very good response, and in our clinical setup also we can see here that in patients with brain mets, so there was with the highest rate of new brain lesions were observed with the chemotherapy arm compared to this 4-drug regimen. The KRAS mutations, so KRAS mutations frequently come with co-mutations STA11 and KEAP mutation. So we can see here PFS and OS benefits with mutant KRAS was quite significant in the ABCP arm, both in the PFS as well as in the overall response rate. The high tumor burden, so in bulky disease, this regimen obviously has shown to give better benefits. So that is another subset analysis for which we should be using this regimen. The PD-L1 status, so we can see here that PD-L1 irrespective of the status in both categories, the ABCP combination has shown benefit. Now the next, the IMPAR 130, which is the non-squamous cells, that was a phase 3 study of carbo and nab-paclitaxel with or without atezolizumab in advanced non-squamous NSCLC. This was the trial design. So in this, obviously, we had the co-primary endpoints of PFS and OS. And here, what we actually learned is that using nab-paclitaxel, which was a potentially steroid-sparing regimen, it had lesser hypersensitivity reactions and was a solvent-free formulation, which we could be using in this regimen. The baseline characteristics were well balanced. The PFS in this study was significantly improved with the addition of the atezo to carbo and nab-paclitaxel. There was also the overall survival benefit with the combination. The overall response rate and duration of response were also improved with atezolizumab to chemotherapy. So in summary, what we can say, the IMPAR 130 had met its co-primary PFS and OS endpoints and definitely showed statistically significant meaningful benefits of 4.7 months overall survival and 1.5 months PFS for atezo plus chemotherapy compared to chemotherapy. OS and PFS benefits were observed across all PD-L1 subgroups, had safety profile with minimal adverse effects, and there were no safety signals identified. And it resulted to support atezo plus chemotherapy as a treatment option for patients with advanced non-squamous, non-small cell lung cancer. This was the safety summary. So from Empower 150, the 4-drug combination, obviously, we can encourage it in all our patients in the upfront setting, especially in the subset that I discussed. And the Empower 130 also in non-squamous histology, it was a potentially steroid-sparing regimen that can also be used for PD-L1 expression 1 to 49 or less than 1%, especially in patients who have got uncontrolled diabetes, comorbidity, or renal dysfunction. So that's from my end. Thank you.